Hi everyone. So apologies for the delay, and could someone please let me know if you can hear me okay? Great. Okay, so that's great. Thank you guys. Okay, so what I'm going to talk to you is about a career in general practice, and obviously I'm a general practitioner. So if you wouldn't mind putting up my first slide, I'll just tell you very quickly about me. And because we're running late, I appreciate that we'll be a little short of time, so I'll try and keep moving through some of the things I wanted to talk about. So if I could have my next slide, please, which introduces me, and while we're waiting for it to arrive, I'll do that. Okay, so I am Professor of General Practice and Medical Education at the University of Dundee in Scotland, and I also run a master's programme in diabetes in Kuwait for many years, and I'm Director of the Centre of Medical Education, and I work for the General Medical Council. So like many GPs, I do lots of different things, and that's one of the great things about the career. It's very flexible. So I am also a general practitioner, and I work in a GP practice in Dundee, and I'll talk a little bit about that later on. So next slide, please. So some of you might have heard of the Centre for Medical Education. If you're into medical education at all, you would know Professor Ronald Harden, and he set up the centre 40 years ago. So one of the good things about running a master's programme in postgraduate development for educators is that I know all about the 32 plus medical schools in the UK, and I know a lot about many international medical schools as well, because our students talk about their work when they are studying on the programme. So I have a lot of experience around different medical schools and different styles. So next slide, thanks. Okay. So what I'm going to tell you a little bit about, as I say, is general practice as a career. And I'm going to do that through the lens of my personal view of general practice, obviously. And it's a UK experience. And in fact, even it's a Scottish experience, because healthcare has devolved quite a lot, and it's different, I think, in all 4 countries in the UK now. However, so I'm going to talk about what general practice is, which seems a self-evident thing, but actually isn't. I'm going to talk about why our patients need general practice or family medicine, why the NHS needs it, and why we do it at the end. Okay, so next slide, please. So as I said, it seems self-evident what general practice is. Many of you will have been to a general practitioner in your lives for all sorts of reasons, so you've got your own perspective on it. But essentially, general practice, next slide please, to me is almost a little bit of everything, and probably a lot of, there's not so many things that I do all the time, but there's an awful lot of things I do most of the time. So here's a definition from Iona Heath, who's a GP in London, who I've known for many years. And she said that general practice is about all aspects of the human existence. And some people talk about that as being from cradle to grave. And indeed, in many practices and many jobs, that's exactly what you are doing. You're working with babies and you're working with people at the end of their lives. But to me, the most important part of it, next slide please, is the primary I talk about of the doctor-patient relationship. And this is really important to me, and I think it probably is to many of us who are GPs for a long time. So like many people as GPs, we can tell our own personal stories of when I told my family I was going to be a GP. Some of them actually said, "Oh, so you're going to be just a GP? Would you not prefer to be a specialist?" And to be fair to them, they probably didn't realise that general practice is a specialty. But here, as you can see, there's a definition of what general practice is all about. This is a European definition of family medicine, and it's got these multiple component parts to it, which is the kind of things you would expect, which is about having a comprehensive approach, primary care management, community involvement, and being holistic. But actually, again, next slide, please, thanks. Even within these broad general areas, there's a lot of other things going on, I think I would safely say. And the slide's probably slightly too small for you to see just now, but it does, if you like, unpick some of the things around community orientation, for example, which says that we're responsible for the health of the community. And probably now is a time when that has become even more apparent than would be obvious, because with something like the COVID pandemic, general practitioners and their responsibility and knowledge of the community is really key to helping battle that. But if you look at that just as a quick glance and you think that the average consultation time is between 10 and 12 minutes in the UK, you can see that there's a lot going on. Okay, so again, next slide, please. So some time ago, the contract changed to also embrace the fact that we are responsible for preventive health, or preventive medicine as it was called. But now it's more dominated by I'm still here, if you can hear me. Good, okay. Okay, so maybe it's just the slides that have vanished. So I can talk a little bit while we're waiting, if you like, and we can try and catch up with the slides, okay? So what I was really talking about was the fact that we had this sort of very rigid approach to delivering care. Oh, you can see them. That's great. I can't. That's fine. What happened then was that many of us realised that it was changing the way we were delivering care, and that in fact it was distorting some of the values of the care we wanted to deliver. And I don't know which slide is up, which makes it a bit difficult. The one I wanted was the one that has a little bit of text in the middle, and I'll read it anyway, even if it isn't the one you can see, which is about a patient who attended for influenza vaccination one day, and when she arrived, she was faced with questions about diet, smoking, exercise, and alcohol. No one really explained why they were asking her. I mean, we knew it's because, that's great, that's the one I'm reading, good. We knew it was because it was about the quality and outcomes framework that needed to complete that data, but actually nobody explained that to her. She had her blood pressure and weight recorded as well, because that was on the tick box list. And after 15 minutes, she left without actually having had the chance to ask about the flu vaccination. Now, that's an extreme example, but it is a real example of how things get distorted. Okay, thanks. So next slide, please, which I'm not going to speak to at length, should be a list of the different elements of the quality and outcome framework, which is in red and black. And really the point of that slide is just to point out that actually there was a lot of things in the quality and outcome framework which were good, but there was also a lot of things that were changing the way we practice medicine, and that was of great concern to many of us. As we've always said, and here's a slide to show that Einstein says not everything that counts can be not everything can be counted counts, and not everything that counts can be counted, because we knew there was a lot more going on in the clinical encounter than that. So that takes me to a slide that should say, what is it, in red? And there's a picture of an article that is distilling the essence of general practice. And that is a piece of research that we carried out in Scotland at the time to begin to try and unravel what it was in general practice that we were missing because of that rigid way of looking after patients. So the next slide has a picture of Iona Heath, and it's got a warm, fuzzy heart. And again, if any of you tell me that's the right slide, that would be reassuring, thanks. So Iona, when we talked about what the essence was of general practice, she described it, well, as the warm, fuzzy heart of general practice. And that's important because it relates to the way we relate to patients, but it's also the way patients feel about us. And that doctor-patient relationship remains really important. So the next slide is where, that's great, we unraveled it a little bit to see what was the essence, and we came up with these 6 different things we thought were really important for GPs to be able to have and to be able to do. And one was that patients trusted us. There has always been a high level of trust in the UK particularly in regard to general practitioners from patients. And that's very gratifying, and hopefully it's something we never lose, because it's about that relationship being an equal one of partners. So it isn't about doctors dictating to patients. Equally, it isn't about patients dictating to doctors. It's about a shared understanding of what the problem is and what needs to be done and how that can be delivered. Continuity is really important in the UK. Many of us have stayed in the same GP practice for our entire lives, and equally many of us work in practices for 30 years. Coordination, because we are the depository, if you like, of all the referrals and letters and information about patients still. You have to be patient-centred and flexible. Coverage, 90-odd% of the population sees a GP in 5 years, and leadership. Okay, so these are really important components. Okay, and I talked there a little bit about the relationship, and empathy isn't new, but it is something that we really value and cherish. And empathy has costs, and I'll talk a little bit about that later, but it is about, that is how you become truly patient-centred. If you can understand and relate to the way patients are, then that works for them and it works for you as well. Okay, so empathy is really important. So we looked at some of the research on empathy and we decided we would build on it. And this is this is where the title of the talk came from. And this is another president, chair and president of the college, David, a very good friend of mine, another GP in London. And he talked about how empathy changed disease into illness. And this is him saying that understanding disease is something we're all taught in medical school. But understanding illness is quite different. It means understanding the feelings of regret, guilt, fear, betrayal, loneliness, and all the other emotions that turn the same disease into a different illness in different people. Sorry. Next slide is why our patients need this. Okay, so. And the next slide after that starts to talk about some of the things that we got back from patients when we started to do this research into the essence of general practice. And many of them said things like it's about being treated as an individual. They recognized that individual care, that they valued the GP's attention and time, that they had confidence to manage things better, and they felt listened to, which is clearly one of the most important things in any doctor-patient relationship. So, however, keeping patients happy is not the same thing as empathy. And that's one of the other reasons that we needed to look a little bit at this concept, because we talk about being the patient's advocate in general practice, that we are there to help our patients steer their way through healthcare service delivery or whatever. But actually that can sometimes be a tension, and sometimes the NHS requires us to do things that is not what the patient wants and might actually not be in their long-term interest. And so we have to fight a little bit sometimes for our patients. And that is something about the doctor-patient relationship. If patients know that we are going to support them come what may, then that is, as I say, a very positive force for good. And a lot of what we do in doctors is based on this work done early by Michael Ballant. And when he talked about this doctor-patient relationship being in its own way therapeutic, that actually people get better because they trust and have faith in the doctor who's looking after them. And that has been proven to be true. People are more compliant, but actually that sense of well-being, if you like, being comforted and feeling safe because someone's looking after you makes a big difference. And as I say, it's a therapeutic approach. It actually does make people better, whatever definition of that is. And we do that through the consultation as well. And that's also an important thing that I'll come on to. So this was a book that was written many years ago about, I don't know, you'll all be far too young to remember Dr. Finley's casebook. I can show you a few pictures of that if you like. But this was about a single-handed country doctor who's lived his entire life in the community looking after it. And there was a piece of research done looking at how he did that, how he delivered care. And one of the things they talk about is that the case histories and the stories that he could tell about his patients underpinned, if you like, his whole philosophy to being a GP in a rural area, in a village area. And he was an expert at storytelling because, of course, stories are what patients tell us. And understanding patients' stories is very, very important. So this was a really nice piece of work, and this slide you should be able to see, which is an open page of a book. So there's a picture of a couple on one side and a gentleman holding a woman who's crying in the other. And this was the cradle to grave element that I was talked about, that actually you bear witness to people's lives. You sometimes, if you're in a practice for many years, you will see them either grow up and become young adults, have their family, care for their parents, or you will see them from middle age to later on in life when maybe they become unwell, and you care for them in the last few months of their life, whatever. But that bearing witness to their lives is something really important, because that's how patients think we know them, because we've seen them 5 years ago when their mother died, or 3 years ago when they had their first grandchild. That kind of thing is really important in patients, because it is, as I say, we know them. We don't need to ask about these things because we know it. So that still happens in general practice, even though that was a long time ago, because again, as I say, many of us are there for many years. And the storytelling is really powerful. I'm going to move past this slide because it's an educational slide, because storytellers are a great way of learning. They are, in fact, about insights into what not just happened, but also what could have happened or what might have been. And so when you're listening to patients' stories, you can probe these kind of areas and perhaps understand a little bit more about, for example, if they've been taken ill and they're telling you what they can do, then you could talk maybe about what the future might hold for them now, different to what they expected it was going to be before this illness happened. So the next slide is to move on to why the NHS needs it, which is the one I'm going to shorten, because a lot of you will understand that the NHS is in dire straits these days financially and also in terms of staff. So healthcare is a social context. That's one of the points to make, really, that, as I said to you, in Scotland, England, Northern Ireland and Wales, we now have fundamentally 4 different types of healthcare systems working. And that's an important element in Scotland, because we're a small country, and although we're spread out geographically, we still have a unified healthcare system. General practice in the Highlands is the same as general practice in the city centre in Edinburgh. As I said to you, I'd tell you a little bit about Dr. Finley. I hope you can see this slide, because it's Dr. Finley's casebook, which shows, and this was when I was going into medical school, and I really wanted to be Dr. Finley. And the next slide shows why, because it shows a beautiful country house in the Scottish Highlands, and I really wanted to live there. And in those days, of course, the house was also the surgery, so it would have been perfect, really, but it didn't work out, because this is where I ended up, and this should show you a slide of Dundee, my practice area. And unfortunately, the next slide shows that it is now should be a GP at the deep end symbol in the top corner, which is a swimming pool represented, and I'll tell you why that's important. But that slide shows how deprived that area is in Dundee now. So it's not a remote and rural lovely area, it's an inner city deprived practice. And the work of the GPs at the deep end was, in Scotland, we looked at the 100 most deprived practices, and to see what the difference was in practicing in an area where there was real challenges because of the extent of the disease pathology that you saw, social and physical, as opposed to when you worked in a rural area where you were doing the same thing, essentially, but it was a lot easier because there wasn't such deprivation around you. So the next slide talks about the link between poverty and illness, and I'll move past that one if we can. Poor Sunny is trying to keep up with me here. And this slide shows a cartoon of a gentleman in black and a lady in a red dress dancing. And this is the inverse care law that Julian Tudor Hart devised when he was working in the Welsh valleys in a mining community which was very deprived. And what he essentially said was that the people who needed healthcare the most got it least. And that's actually true. So when you actually look at healthcare divide over decades, you will find that people in deprived areas receive less healthcare in real terms than people in more affluent areas. And that's partly because demand is so much higher. But then he decided fairly recently that he would refine that to actually, it's those who need the most ask least. because poverty is also about poverty of expectations around what health can be achieved. So many of my patients don't expect to live into the 70s and 80s. They really don't, because their father didn't or their mother didn't. They have already maybe got some long-term conditions in their 30s and 40s, and so they don't expect to have the same longevity, and they don't ask then. They accept illness much more than I would, and they put up with things that we wouldn't tolerate because we would ask for help. So still within that, the doctor-patient relationship's really key, and I'll just want to jump a few slides because we are short of time. So if you can keep up with me, Sonny, sorry about this, then if you could just jump to the next slide. That is, sorry, just give me a second. Oh yes, back to that slide with the essence of general practice image on it, and it's entitled Why We Do It. Okay, because presumably one of the reasons you're watching a presentation on a career in general practice is you're interested in taking on a career in general practice. So again, if you could just tell me if you can see, for ease, I'll put up the next slide on my screen, which is Why We Do It, Professional Satisfaction, and it's got the warm fuzzy heart and it's got a Swiss Army knife. Is that the one you can see? Yeah? Great. Okay. All right, so personal satisfaction is very important, okay? I mean, I actually do freely admit I went into medicine because I wanted to help people, but I like helping people because it makes me feel good to help people. Oddly enough, when we looked at all the research we did in the essence, we found that almost always patients said they expected their doctor to be competent. I mean, you'd think it was a given, but sometimes we wonder. But actually, no, they assume we're competent before they've even met us and that we practice safe medicine, okay? But what they said was, and this is referenced again by Martin Marshall, as a professor in general practice, that the best general practitioner knows when to act, when to wait, and when to refer. Okay, and a lot of times when we were teaching perhaps trainees, it almost can come across as a kind of sixth sense that you intuitively know when the person with the headache, that particular person with headache, when you've seen hundreds of headaches, is the one who may well have a brain tumor and you want to refer them. That is a kind of sixth sense, but actually it's highly skilled learned behavior. It's about picking up on things that you wouldn't obviously see, but because you've seen so many of these conditions that you pick up on the difference. What is the difference? Okay. So the next slide then, please, is, I'm sorry, I'm catching up with myself here now, is, coming back to the stories. So a lot of what we do is, I say, is listening to patients' stories. And it's these stories that give us that, if you like, sixth sense intuition when things are out of step with normal, because we listen to so many normal stories about headaches and what it's like and what it's doing and how it feels and what they've tried, that there'll be something in that story that one that triggers that, I'm concerned about that patient, that does it. Because here's Trish Greenha, another professor in general practice in London, who talks about the interpretive act of clinical medicine. Okay, that's about drawing out the stories, but it's about putting together the results, the findings, and your own experience and understanding of what's going on around at the time. You know, many of us say there's a lot of it about, for example, when we're diagnosing flu, then that's another example of how the interpretive act of medicine of clinical medicine is what we do and we do best, okay? And we do that through the consultation. And the consultation is something I teach a lot about because, again, medical students, again, are taught a very formulaic way of asking questions. And that's important because you don't want to miss out key questions that give you meaningful information. But actually, the story and the way you elicit the story while you still ask these meaningful questions is the skill of a real consultation. And it's about, at the end of it, patients feeling that they've been listened to and valued, and you've got a negotiated and balanced way forward that sometimes might be not what you would want as your first option, but it's the best that you can do because the patient does want something different to that. So again, it's a perfectly reasonable thing to do. So why else would you go? Next slide, please. So this one should be showing you some of the nice places that you could work if you were a GP. And I've tried to be fairly selective, although I just realised looking at it that only 2 of them are not in Scotland. So I'm really sorry about that. We actually send students on longitudinal clerkships from Dundee for 3 months if they like, and they go to the Western Isles or the Orkneys or the Highlands, and they spend the 3 months there doing general practice, but also medicine and surgery, because these are remote and rural areas where all of these things are done. We've got pictures, students send us back pictures of hanging out of air ambulances as they're flying from the Lewis to Edinburgh and things like that, so it's good. Inner city practices are also popular in many ways, because people like to live in the city, and that's good. And then there's the more the suburban kind of approach where, and I worked there for many years, where my kids were at school with the kids in my practice, and everybody knew everybody, and that was nice. But it's, as I said to you, it's the long-term nature of it. So if you're part of a community for a long time, you get to know all about it, and you know who knows what. I once used to say to my students, please be nice to Mrs. McGregor, because if you're not, you'll upset 113 other patients in this practice, because she was the great-great-grandmother, and she had 13 children, and many of her children had 13 children, and a lot of them still stayed there, and they were all patients in the practice. So you had to know that, because a lot of it was really interesting as to the family relationships. So I say it's like standing in a Scottish mountain where the mist kind of soaks into you, no matter what you're wearing. You gradually absorb a lot of the environment and the culture. Okay. Which takes me back to, if you like, the notion at the very end of this talk, okay, which is that general practice is a specialty that is very rewarding for all sorts of odd ways. It speaks to your values. Patients are incredibly supportive, and I gain a lot from my patients. They give me almost as much as I give them, I think, at times. And so to finish the piece of research that we did, and this should be the slide that says empathy changes disease into illness, and it's the 100 words, and it should have the book at the top and then a picture of James Willis down at the bottom. And I will read this one because this is my favourite quote. We asked all of them to write 100 words about the future of general practice, and this is James Willis. And he said, the role of the general practitioner has not changed. It is open-ended, inclusive rather than exclusive, dealing in wholes, not parts. It is personal, continuing, and it means making the patients feel you care about each one of them. It is about respect, trust, independence, and personal integrity, founded on science and yes, evidence, but it also involves the reconciliation of incompatibles, irrationalities, and impossible expectations. It rejects the inhuman and the formulaic, and involves privileged access to other people's deepest secrets, their bodies and their homes. And I think for me, the bit that really stands out, the bit that's really challenging, and the bit I get most, if you like, intellectual reward from, is that bit where you have to reconcile incompatibles, irrationalities, and expectations, and patients therefore leave your surgery feeling they've been listened to, they've been valued, and they've been cared for. So my very last slide is the one for the Royal College of General Practitioners. I'm sure if many of you are interested in general practice, you've already looked at this slide. I was chair of the Royal College in Scotland for 4 years. I know that the Royal College is an excellent source for helping you understand the opportunities in a career. They will answer questions. They also, of course, run the exam, the assessment for specialty training. So that's the website, go to it, ask questions, and also my email's in the presentation. If you want to contact me about anything, then you're very welcome to do so. Okay, I think we've run out of time. So unless anyone's got 1 or 2 quick questions they want to ask me, then I probably should draw it to an end. Okay. Well, thank you all very much for listening, and I've enjoyed talking to you. And I'm sorry about all the difficulty at the beginning, and also want to thank Sunny for sharing the slides with you, even though latterly it wasn't with me. Okay, so thank you all very much, and I hope you enjoy the rest of the conference. Okay, bye for now.